Welcome to our webcast. I'm Frank Long, Editorial Director of Rehab Management. Our topic for this program is standing, and we're going to look at some of the ways therapists can build their standing expertise. We'll also discuss some of the important developments in standing technologies with a special look at wheelchairs that have standing features. We're also going to explore the patient's journey to standing and learn some important tips every therapist who works with standing should know about this specialized area of practice. Leading us on this exploration is Jillian Cacopardo, a physical therapist and the clinical program coordinator for wheelchair assessment services for Gaylord Specialty Healthcare, a provider of complex medical care and rehabilitative services located in Wallingford, Connecticut. Jillian wrote a feature article about standing in the 2021 March-April issue of Rehab Management, and we're going to expand on some of the topics she discussed in this presentation. Jillian, welcome to the program.
Thanks for having me.
How much of your current practice was developed through your own personal experience?
Probably all of it. It's not something I learned in school. It's something that I've picked up along the years. I worked in inpatient rehab prior to becoming the clinical specialist, and was able to work with standing with my inpatients, and that definitely helped guide my practice to now.
Let's talk about the journey to upright. Jillian, describe the path that most patients take in their journey toward upright.
If someone comes in and they have already expressed their desire to stand, they may or may not have already undergone a standing program. If not, then we will make sure that they're cleared medically through their physiatrist or their primary care physician. We get that information, and then we would have the patient trial a standing program. We just want to make sure that they can progress towards upright. They don't necessarily have to achieve full upright before we would see them again to spec out the equipment, be it a stationary standing frame or a power standing chair with a standing feature. But we want to make sure that they can progress towards upright, and then we would see them again, spec out the equipment, and hope for approval.
Are there clinical or social indicators that suggest standing may not be a suitable goal?
I think that's on a case-by-case basis. I think everything can be read on the flip side of the coin. So if somebody gets orthostasis when they go to stand, that can be considered a contraindication. But if they stand, they may be able to work themselves out of the orthostasis or the impaired skeletal structure. If they're osteopenic or osteoporotic, could that help reverse or slow down that progression if they do stand? Obviously, there's a risk involved, so I really do think that it's a case-by-case basis. From a social indicator, I do think that is a big factor, particularly with a lot of our clients. They live in the inner city, and they have some aides that are there in the morning and there at night and not there for the amount of time that they would need to stand, or take the time to transfer them in, stay them while I stand, transfer them out, still do everything else that they need to do to care for the patient. So I think that lack of caregiver support may be a indicator of not to stand, but we still try to promote that it's doable for them. But that's definitely one of the more probing questions that I look to ask when somebody comes in to request a standard.
One thing we see in the market now are standing wheelchairs. Tell us about power wheelchairs that have standing options versus separate dedicated standing systems.
I think the power wheelchair market, or the power wheelchair market with standing feature, has actually has increased or gotten larger over the past few years. I think the old school was kind of just a front wheel drive power stander, but there's other manufacturers out there now that have been able to put a mid-wheel drive or a power stander on a mid-wheel drive base. And I think that for people that have more home accessibility issues where the power or the front wheel drive won't fit, I think that it's opened up a lot more doors.
When you consider all the factors of function, health benefits, cost, and probability of user abandonment, is there one type of standing technology that seems to check all the boxes?
As far as health benefits, making sure there isn't user abandonment, I think the power standards is a big key to helping people be able to stand, because they don't need somebody to get them into a stationary stander. They don't need multiple caregivers to get them set up. They can just press the button and they can elevate into standing.
In your article, Jillian, you mentioned that medical clearance sometimes may benefit from the input of an endocrinologist. Can you share some more details about why that is?
So the patient had it stood for greater than 5 years. And due to the nature of his disease, which is multiple sclerosis, he was unable to transfer to obtain a bone density scan. So I believe his blood work had also revealed a vitamin D deficiency. So his primary referred him to an endocrinologist because they could do their risk assessment for further fracture or pathology of the bones. So that was why the endocrinologist became involved. But that was a first for me. Usually it's been either a bone density test or an X-ray saying yes, everything looks good, they can start a standing program.
Do you have any tips for reducing equipment abandonment?
Whoever's going to be involved in setting the person up, be it transfer them to the standing frame, or if the patient can't actually get in like the chest piece and the knee support and power stander, that they are there to trial that with them. Because too frequently I've had patients come back and I'll ask them if they use their stander and they say no, and I say why, and they say because it's too hard for me to transfer into, or it's too hard for the caregivers to transfer me into, or because unfortunately or fortunately, we're able to use an overhead lift here, and not everybody has an overhead lift at home. And I think that that's a huge contributing factor, because I think everything can be easier with an overhead lift. So without that, it's a big difference in transfers.
Here's a question that will be of interest to every therapist who works with standing. Jillian, do you have any suggestions for how to fund a standing technology?
I think if you're able to show the insurance company or the funding source how successful somebody is in standing, how committed they are to their program, how their caregivers are able to assist them if necessary, I think that that helps with the funding. Obviously, you need to know what the funding source is, what is written in their policies, because some policies are written outright that standing is not covered, or maybe a stationary standing frame is, but the power feature is not. So definitely look to that, and then know your external sources too, different foundations that you can submit to, or GoFundMe pages, or, the social networking sites that may be able to help you, because you may be able to get your pieces covered and not, for example, like with the power chair, you can get the power chair covered, but not the standing feature. You could pay for that privately. So just know that there are other avenues to potentially get there to meet your standing needs.
We've been speaking with Jillian Cacopardo, a physical therapist and the clinical program coordinator for wheelchair assessment services for Gaylord Specialty Healthcare, Wallingford, Connecticut. Jillian, thank you for joining us.
Thank you so much for having me. It's been a pleasure.